sake of time, يعني because we are late already, we have to start our session. Our session will be on cardiogenic shock from all aspects. As we know, cardiogenic shock is a fatal condition. However, يعني it is a rare condition. Although we have a great success in the management of cardiogenic shock, still it carries a very high risk of mortality. The first lecture will be given by Dr. Ayman Gad from Riyadh about the management of cardiogenic shock in 2024.
بسم الله الرحمن الرحيم. Good morning, Mr. Chairman. Good morning, everyone. My talk today about management of cardiac shock. Cardiac shock, one of the most important topics in our daily clinical practice. It carries high risk of mortality or morbidity till now. First thing, to manage cardiac shock, we should define the cardiac shock. For several years, there were several definitions of cardiac shock. To summarize, to diagnose cardiac shock, you need a marker of tissue hyperperfusion in addition to decreased cardiac index plus systolic blood pressure less than 90 millimeter mercury for more than 30 minutes or need support to maintain this systolic blood pressure. One point to remember is to intervene early and escalate your therapy early before going to the phase of severe refractory cardiac shock. Regarding the cardiac shock, it represents about 66% of all cause of shock. Regarding cardiac shock itself, as you show in the right diagram, it is not single cause but multiple causes, and this is one of the challenging in treatment. Roughly, we can classify cardiac shock into acute MI cardiac shock and non-acute MI cardiac shock. Fortunately, all types of cardiac shock has the same pathophysiology. So, first step is is this cardiac shock true? What is the severity? It is right or left or biventricular? What is the support options? This states that we should have the same language regarding speaking about cardiac shock. And the SCI definition aiming to make this same language from the stage A to B to E. Simply, if we have a patient with acute cardiac disease, we should ask ourselves first question: is there any signs of hyperperfusion? If yes, it is established shock. It is class C. If no, it is not a true shock. But regarding classification of SCI, we will ask second question: is there any hemodynamic instability? If yes, it is a pre-shock or stage B. If no, it is stage A, or at risk, like a patient with large acute anterior MI. In order to remember this classification, you may show this image. Regarding mortality, in last 5 decades, if we take a rapid look from 1988, there is the first drop in mortality. That's why it was the time of induction of revascularization therapy. After that, the mechanical stroke support show no improvement in mortality, and at 2019, there's a drop also in mortality. That's why, because of cardiac shock team. In management of cardiac shock, we should emphasize the role of revascularization, the role of medical therapy, the role of acute mechanical circulatory support, and the role of multidisciplinary shock team. The role of revascularization. As I said, it is one of the most important weapons that improve mortality in cardiac shock. Of course, in patients with acute MI cardiac shock. Every patient with acute MI complicated with cardiac shock, it is mandatory for revascularization, either by BCI or CABG, according to the situation. Also, in setting of hemodynamic instability due to mechanical complication, emergency surgical or catheter-based repair of mechanical complication is recommended based on heart team discussion. In case of Not available, a primary PCI within 120 minutes, thrombolysis should be considered in this patient. And remember that the revascularization for the culprit only, and then stage for the other vessels. The role of medical therapy. Second line is medical therapy. You have the vasopressors, the inotropes, the inodilators. But what is the criteria of the ideal drug to treat cardiogenic shock? We need drug increase contractility, increase mean arterial blood pressure, maintain diastolic blood pressure, increase cardiac output, improve regional perfusion without increase in myocardial oxygen consumption, with no tachycardia, non-arrhythmogenic, suitable in pregnancy and pediatric population, non-toxic, stable respiration, cost-effective. Which drug? Of course, there is no drug carries all these criteria till now. The available drugs is noradrenaline, dopamine, dopamine, milrinone, and vasopressin, methylene blue, and will be discussed in details in the next presentation. Simply, how to initiate medical therapy in patients with cardiac shock. Assess first, it is normotensive or hypotensive. If normotensive, we'll start with dopamine or milrinone. If hypotensive, we'll start with norepinephrine. Third line is device therapy. We have intracorporeal and extracorporeal devices. So intracorporeal such as intra-aortic balloon and Impella, extracorporeal such tandem heart and VA ECMO. Our goals of therapy in mechanical circulatory support is decongest, to unload the ventricle, to minimize the complication, and to reduce organ injury to achieve end-organ perfusion. And the fourth line of treatment, and the most important, is the role of multidisciplinary shock team. And it is, as we show in the graph of mortality, change mortality rapidly. And I think this is the most important topic today about the multidisciplinary shock team. And it's the class 2A in guidelines. What about this team? Cardiogenic shock code, it is a team of personnel and infrastructure. Has a leader, has the authority or its role to include the selection criteria for cardiogenic shock, to know the capacity of rapid contact between centers, to protocol-based indication for and the type of mechanical circulatory support. They classify the hospitals into 3 levels. Level 3 is the community, is the common hospitals in our areas, which has the vasoactive drugs, hemodynamic monitoring to diagnose and advanced life support. Level 2 is the center with primary PCI and capable of doing mechanical circulatory support, and level 3 is advanced heart failure. What is the aim of the multidisciplinary cardiogenic shock team? First, ensure rapid diagnosis, identify the specific phenotype, assign the appropriate level of care, make decisions on interventions and mechanical circulatory support, recognize futility and adopt palliative measures, identify candidates for clinical trials. Members of the team. First, physicians and nurses from the hospital emergency departments and out of hospital emergency medical service. Critical care cardiologist, anesthesia, cardiovascular surgeon, and critical care nurses. Cardiologist is specialized in heart failure and transplantation, and lastly, the perfusion team. And also, and of course, interventional cardiologist and interventional nursing staff. This is the role of every person in the shock team, and this summarize one of the shock team or shock code protocol. There is some perspective treatment of cardiac shock ongoing till now, not proved, but there's ongoing trials about it. And the future for EMR and AI, like this application, cardiac shock working group, this application that easily we can use in daily practice, will show you the shock stage and hemodynamic calculator, and even alarm you when deteriorating the shock state of the patient. Take home message, cardiac shock is a fire. Try to prevent it. Mortality from cardiac shock remains as high as 40%. Use the sky shock to communicate prognosticate and motivate. Don't wait until the house is burned down. Revascularization of culprit lesion remains the gold standard for acute MI cardiogenic shock. The team-based approach shock team improves outcomes. In the era of mechanical devices, medical therapy remains the cornerstone for myocardial recovery. New therapeutics are currently being assessed in ongoing trials. And thank you.
Thank you, Dr. Ayman. I want to ask you about, you mentioned ECMO as a extracorporeal tool. What is the exact indication of ECMO in this situation? Was it used alone or with other support or what?
Nice question, Dr. Muhammad. ECMO, it is the end of the devices as it needs unloading to unload the ventricle. You know, it make the ventricle loaded. So usually it used with such as Impella devices. With other, yes. Yes.
Okay, thank you. The second speaker, Dr. Muhammad Suleiman, is lecturing how to tailor inotropes in the cardiogenic shock.
Thanks, Mr. Chairman. I would like to thank the organizing committee for presentation of a very important topic, how to tailor inotropes in cardiogenic shock. Dr. Ayman do a very good lecture, and he made my work easier. First of all, we have to Okay. I will start my talk with the key points. We will introduce the introduction for cardiogenic shock and how we can tailor our vasopressors and inotropes. Is there a comparative studies for this issue? Hemodynamic monitoring, is it essential or not? Suggested algorithms, as there is no international algorithm we have all to stick to. Specific situations and the take-home message. Cardiogenic shock is a clinical syndrome characterized by insufficient cardiac output to meet basal metabolic requirements, leading to life-threatening end organ hyperperfusion. This is a definition we lastly reached. Prompt hemodynamic support is essential to restore cellular metabolism and to prevent worsening systemic and myocardial ischemia, which drives the shock spiral, in many cases lead to circulatory collapse and death. Despite advances in treatment options, cardiogenic shock mortality remains high as 50%, and the initial goal for therapy for cardiogenic shock should go into sideways, but in the same time to know the underlying cause and to improve the tissue perfusion. If you know the underlying cause of the shock and you start urgent revascularization, this is definitely decrease mortality, and the tissue perfusion and oxygenation. This will let you to use the vasoactive medication who is on the best choice, and this should be with the minimum acceptable cardiac output and the blood pressure to be achieved in this condition. If we revise again, Dr. Ayman stated this issue is management patients of cardiogenic shock. We have an emergency PCI or surgical treatment. It's an urgent indication, and at the same time we have to identify the specific cause. But as you can see, the European Society consider inotropes and vasopressors in general, and this was a class 2B. Till now, we still don't have a specific algorithm, or unless we do very good comparative studies. Improvement of hypoperfusion is essential. Also, we have to consider oxygenation, it's class 1, and ventilatory support as a class 2A if we need. Then after this, we can start for weaning of vasopressors and inotropes. Here is a problem list: which inotrope, when to start, how can we escalate the inotropes? It's a big issue. According to European Society to 2016, they have stated that inotropes, dobutamine, dopamine, levosimendan, phosphodiesterase, they stated them with each other, but the norepinephrine as a vasopressor was class 2B, with preferably to be used in cardiogenic shock if there is a hypoperfusion or decreased blood pressure. But the intravenous infusion of levosimendan or phosphodiesterase inhibitors was essentially used to reverse the effect of beta blockers if you want to use another receptors. But the studies still, inotropes agent are not recommended unless the patient is symptomatically hypotensive or hyperfused. It's all a very rough indications. Then we go to 2021. Even we removed the name of the vasopressors, just the norepinephrine, which is still with us. Vasopressors, preferably norepinephrine, may be considered in patients with cardiac shock to increase blood pressure and the vital organs. This is a class 2B, B. But inotropic agents, no names, no dobutamine, just for general, with systolic blood pressure less than 90 and evidence of hypoperfusion who do not respond to standard treatment. Inotropic agents are not recommended routinely due to safety concerns. Still, we have safety concerns unless the patient has symptomatic hypotension and evidence of hypoperfusion. And here is the question: is this sufficient? The guidelines to 2021, there is no mentioned vasopressors or inotropes, just the norepinephrine in case of hypoperfusion. So we have a missing parts for this issue. The definition of cardiac shock is not constant all over the studies, and this makes the meta-analysis and the studies very difficult, and you cannot include all patients as each other. Worldwide accepted decision-making algorithm on the management of cardiac shock is still missing. We have another issue. There's a limited information about comparative efficacy among pharmacological vasoactive agents used in cardiac shock. This is also an important issue. Regarding the definition of cardiac shock all over the years, since 1999 in shock trial or intra-aortic balloon shock trial and card shock and French shock, we have many changes. Here, the hemodynamic criteria in early years was about the cardiac index and the pulmonary blood pressure. At this time, Swan-Ganz was much used. But then we shifted to the hypoperfusion and how we diagnose it. Lactate started to be there, and oliguria, skin mottling. We start to know that hypoperfusion is an important issue in cardiac shock. Even with other trials, Empress trials or Calvert trials, European Society Heart Failure Guidelines, also there is a different definitions. This makes the studies more difficult, and laboratory hypoperfusion as metabolic acidosis, elevated serum lactate and elevated serum creatinine start to be added with the European Society of Heart Failure Guidelines without specific numbers. So the SKY started to help us to stratify the patients, as Dr. Ayman said, as patient at risk, patient in the beginning, classic, deteriorating, and extremes. Classic and deteriorating is considered more severe cases, and this will make the studies in next years more easier. As Dr. Yesterday, I heard and very beautiful session about cardiogenic shock, and you, Dr. Tim said that this SKY stage will make the cardiogenic shock assessment more easier. And this was reflected on the years 2023 and 2024. The studies start to be more specified. But this will make the old meta-analysis more difficult. This is a number of included patients in a major randomized studies. As you can see, very low numbers, 55, 80, 70. Small numbers. Definitely, we have insufficient data, weak points, and greater space for expert opinion. So the vasopressors we have, as we can know, catecholamines and phosphodiesterases and calcium sensitizers, those are the major groups and how they work about the muscles, increase chronotropism and contractility. And here is the vasopressors we have, dobutamine or vasopressin and catecholamines, levosimendan, how they work on the on the vessels itself. The dobutamine, adrenaline, dopamine, and non-adrenaline, those are the adrenergic group we have. You have to know that dobutamine is a beta-1 mainly, and at lower dose, at higher dose, it's also a vasodilator effect. You have to know what is your dose. Adrenaline also is the same. Dopamine at low doses, dopaminergic, then cardiogenic, then vasopressing. Noradrenaline is the same. It's mainly alpha-1 agonist. All of them have ventricular arrhythmias and cardiac ischemia can happen. Inodilators like levosimendan and milrinone. This one starts through troponin C intracellular calcium, levosimendan. It's also causes tachycardia, hypotension, and enhanced AV conduction. It's calcium sensitizer. Milrinone is a phosphodiesterase type 3 inhibitor. Also can cause positive inotropism, but it have a hypotensive and ventricular arrhythmia effect. What is ideal catecholamine we have? Dr. Ayman said this slide. It's non-toxic, very compatible, increase contractility, increase mean arterial pressure, maintain diastolic. This is not happen. This will not happen anyway. What we have now, the vasopressors and inotropes, increase myocardial oxygen consumption, increase myocardial ischemia, can trigger arrhythmias, can cause infarction expansion, can worsen peripheral tissue perfusion, and no clear benefit. This is the truth. So, the comparative studies we have, randomized control studies, inotropes have been difficult to perform. Current recommendation on the use of vasopressor through meta-analysis, expert opinions, and the review articles. Norepinephrine is the most frequently used vasopressor for treatment of cardiogenic shock with dobutamine and levosimendan to be added on. These are the studies done on inotropes and the vasopressors. You have to see there is no difference in mortality in most of the studies, except the study was Tarvanes in Finland on 219 patients. It increased the mortality with epinephrine, and this study kills the epinephrine for a while. All of them are dopamine versus catecholamines, levosimendan versus dobutamine, milrinone versus dobutamine. All of them, most of them with no difference in mortality. Even levosimendan have some comparative data, which is very different. One time it lowers the mortality, one time it increases the mortality. This is randomized studies, Capital and Optima CC, SOAP2, CAT. Most of them also, they have mortality, no difference, as you can see. But some of them, we have known that epinephrine increases factory shock, can increase double product serum lactate, increase arrhythmias also with dopamine. We get some data, but this was not different in mortality. This is a study was done for adrenaline. As you can see, adrenaline decreased survival. Other vasopressors was better. Noradrenaline, levosimendan, and noradrenaline dobutamine was in comparable stage. This is a levosimendan versus dobutamine also. Also, there was no big difference except with levosimendan and the enoxamine. Comparison of norepinephrine. This is a study where the European Society depends on that cardiogenic shock mortality decreased with norepinephrine if it's used in comparative to dopamine, and when the sub analysis for cardiogenic shock patients, it makes a difference in mortality. This is a Cochrane study done on vasopressors for hypertension shock. They have done 28 randomized controlled trials on 173 mortality. The authors conclude no evidence of substantial difference in total mortality between several vasopressors. No one is better than the other. So, inotropic agent and the same study, but on cardiogenic shock on low cardiac output patients. At present, there is no convincing data supporting a specific inotropic vasodilating or vasodilating therapy to reduce mortality in hemodynamically unstable with cardiogenic shock. Cochrane study done on 19 trials. These are the only randomized control trials. So the key points is that dopamine have high mortality, arrhythmogenic, better not to use in cardiogenic shock. It's dose dependent. Adrenaline increase myocardial oxygen demand and lactate. Noradrenaline lower the mortality, lower myocardial oxygen consumption. Dobutamine is the initial agent of choice with norepinephrine. More arrhythmias, dose dependent tachyphylaxis. Milrinone can be used for non-adrenergic pathway as beta blockers patients. Levosimendan the same, but some conflicting data, and it's expensive, and post-cardiac surgeries have good results. Vasopressin, better to be used in septic shock. Just post-cardiotomy vasoplegia can be helped, and also it doesn't decrease the pulmonary pressure. So the milrinone and the vasopressin can be used for patients with pulmonary problems. Do we have to have an invasive hemodynamic monitoring? Yes, we have. This is a study done in Journal of American Heart Association. It concludes that patients with cardiogenic shock with invasive hemodynamic monitoring, they have more reduction in mortality. What we can do, we have to do just an arterial line. It can help to monitor the patients. But pulmonary artery catheter could be used, but we have some debates. Echocardiography should be done daily. The ESCAPE trial, which I have done on the pulmonary artery catheter and which removes the pulmonary artery catheter from the studies, didn't enroll cardiogenic shock patients, and they have a contractor result. Sometimes we get some benefits from the invasive measuring. The heart team and shock team, as Dr. Ayman said, we have to be a multidisciplinary shock team. It should be intervene with the patient critical and according to their stage. Interventional cardiologist, cardiothoracic surgeon, heart failure specialist, intensivist, and even ECMO and perfusion team should be included. This is the algorithm suggested by Jose Amado in 2016. Mean arterial blood pressure less than 65 or left ventricular ejection fraction less than 40. We have to start if RV functions is elevated or not. If yes, start milrinone or levosimendan to be better with norepinephrine. If it go well, okay, continue. If not, you can add vasopressin. If not, RV is well, begin dobutamine. If mean arterial pressure is low, start norepinephrine. Or if not controlled, you can add vasopressin with some precautions. This is also the algorithm stated by the Journal of American Heart Association. The same as we say, assess cardiogenic shock. If patient normotensive, you can add dobutamine or milrinone. If not, if hypotensive, start norepinephrine, and then you assess again. If low output state still there, you can add dobutamine or milrinone. If not, patient is not responding, you can add vasopressin or even turn to methylene blue. The specific situations, you have to choose your inotrope or vasopressors. First of all, a patient on beta blocker, levosimendan and milrinone will be better. If the patient has pulmonary hypertension, levosimendan also and milrinone will be better. If patient is heart failure with ischemic etiology, dobutamine can be added. Cardiopulmonary bypass, for if vasoplegia, you can add milrinone, dobutamine, or levosimendan or vasopressin. Sepsis related heart failure, norepinephrine is a drug of choice with dobutamine. So when to start to wean? I need 1 minute. We start weaning when the hypoperfusion lactate is decreased and the cardiac index start to be in the normal. Improvement of vital signs, diuresis improved. Other inotropes still under study or digoxin need to be revisited for heart failure. So my take-home message: the mainstay of therapy for cardiogenic shock is still the use of inotropes and vasopressors. Lack of evidence for clinical benefit due to weak, underpowered studies for current available inotropes and vasopressors urge further mega studies and analysis. Treatment tailored by assessment and optimization of perfusion through invasive hemodynamic monitoring. Proposed algorithms according to cardiogenic shock stage should be prompt and revisited. شكرا.
Thank you, Dr. Muhammad, for your informative talk. Now we'll shift to the third lecture. Based therapy for cardiogenic shock. Inshallah, will be given by how the mechanical circulatory support, when and which one. Final word is by Professor Igno Harnes.
Thank you. And thanks the organizers for inviting me, and I'm very sorry that I can't be there in person. So my task is now to wrap up if there is anything else than inotropes. I probably can say at the moment, probably no. These are my potential disclosures. Looking at cardiogenic shock mortality over time, we have come a long way, but if you look at perceived mortality from clinical trials at present and from registries, there is still around a 50% mortality. So what is currently available in terms of mechanical circulatory support? There is, of course, the old intra-aortic balloon pump, although at least in Germany and in some other countries, it's not being used anymore for cardiogenic shock because we had the big trial that showed us its neutral data. We also have the left ventricular assist device that is removable, the turbidometric impeller pump, although we don't have any randomized trial data yet. And then, of course, there is the extracorporeal membrane oxygenation, veno-arterial, the VA ECMO. All the other procedures that I mentioned here are in the hands of the cardiac surgeons and are more or less bridge to transplant or destination therapies, but not therapies that are routinely used for treating patients with cardiogenic shock. After we've seen this EABP shock trial with the neutral outcome, there was a class 3 recommendation not to use the EABP shock in cardiogenic shock from the European Society of Cardiology, although there might be circumstances where it is still being used. I can say, at least in Germany, we don't use it anymore, at least for cardiogenic shock. What we have seen since this EABP shock trial we are struggling to find something where we can save patients that are probably quite young, who may have been resuscitated or who may have gone into cardiogenic shock due to acute myocardial infarction. So we always try to do something in addition for the patient, in addition to primary PCI and to inotropes. And that explains why we've seen a dramatic increase in VA ECMO in these patients over time. So far, we have one big randomized trial that has been published last year. That's the ECLS shock trial. And this was a trial investigating VA ECMO in patients with myocardial infarction-derived cardiogenic shock. I will go in that a bit more in detail in the next slides. There's another trial which is currently being it is finished and it has been submitted and will be presented, but unfortunately not today. It's at the American College of Cardiology meeting Sunday, 7th of April, and that's the DanGer shock trial. It's a trial that initiated in Denmark, and the idea is to use an impeller pump in patients with cardiogenic shock. Due to the slow recruitment, they extended the trial into other countries, and that's why it is called DanGer, because Germany was one of the countries contributing most of the patients after they combined the Danish and the German cohort. So the trial is finished. We don't know the results yet, so therefore I can't disclose anything, but we're looking forward to the results. Looking at ECLS shock, most of you have probably seen that and read the paper. This is just a small wrap up. So we just learned about the SKY stages for cardiogenic shock, and they're very useful to design future trials. So the patients that have been included in ECLS shock, they had to have a acute myocardial infarction with a cardiogenic shock complicating this acute myocardial infarction. So it's the pure cardiogenic shock by acute myocardial ischemia. The patients also needed to be scheduled for revascularization, and the systolic blood pressure needed to be below 90 millimeter Hg, or at least 30 minutes of catecholamine use to maintain a blood pressure above 90 millimeter Hg. In addition, there had to be signs of impaired organ perfusion with at least one of the following criteria, either altered mental status or cold and clammy skin and extremities, or oliguria with a low urine output of below 30 mils per hour. And the fourth criteria that had to be fulfilled is arterial lactate bigger than 3 millimole per liter. Of course, informed consent was necessary. So these four criteria had to be fulfilled. So if you look at the criteria, you can really see this is patients that are in later stages of the SKY shock pyramid. The trial was mainly recruiting patients in Germany, and about 877 patients were screened. A bit more than half or less than half were randomized, and the follow-up was excellent, so that the final analysis included 417 patients. And the primary endpoint was death from all causes, 30 days post-randomization. If you look at the treatment, most of the patients were treated by PCI, which is what you expect from an acute myocardial infarction. And if you look at the use of VA ECMO, most of the patients also were supported with an antegrade perfusion sheath in order to prevent peripheral ischemia. And there has been a discussion about the usefulness of ECMO in cardiogenic shock, because you're increasing the afterload of the ventricle, although you stabilize the circulation. And there is the idea to do simultaneously left ventricular unloading by using another device, which most of the cases would be an impeller, but it could also be an intra-aortic balloon pump. So in this trial here, there was a low percentage in the ECLS group that had left ventricular unloading, and the group that is not receiving VA ECMO, you can see that a bit more patients received left ventricular unloading than in the group with ECLS. And other mechanical circulatory support devices were also used in the group that didn't receive VA ECMO. So the results were a bit disappointing. We didn't see any significant difference in 30-day mortality between patients that received ECLS for cardiogenic shock derived by acute myocardial infarction versus the control. What we did see, on the other hand, in terms of safety, we did see more moderate to severe bleeding with patients receiving VA ECMO, and we also did see more peripheral ischemic vascular complications. This has also been shown in a subgroup of patients, which was about 2/3 of the patients that had out-of-hospital cardiac arrest and were resuscitated before they were entering the trial. So we always saw that there was not a difference in terms of mortality between ECLS and, let's say, non-ECLS therapy. Of course, it may include some other mechanical devices, but only up to 15% in this group. And we did see a dramatic increase in bleeding. So, having seen this, we're now looking forward whether pure left ventricular unloading without VA ECMO might be something that is helpful for cardiogenic shock. So this is the danger shock study that will be presented at ACC in April. This includes patients with cardiogenic shock randomized within 24 hours. The lactate level that is necessary is a bit lower. It's 2.5 millimole compared to the ECLS shock trial. And the blood pressure is a bit more liberal, so it had to be below 100 millimeter Hg or the use of vasopressors. And the left ventricular ejection fraction should be below 45%. The primary endpoint here is a bit different. It's not the 30-day mortality, it's the 100-day mortality. And the statistical assumption is a bit wider. So if you remember the first slide that I showed, we more or less have a 50% mortality across the trials in cardiogenic shock. In these days, there's the assumption that there is a 60% mortality with cardiogenic shock in the control group, and that the reduction with the use of this left ventricular unloading would be 12%. And the planned number of patients was 360, so I can't disclose anything more. And we're looking forward what the left ventricular unloading in cardiogenic shock is able to provide for the patients. There's also a matched cohort study which actually used the idea of having the extracorporeal membrane oxygenation VA ECMO in cardiogenic shock, in addition using a left ventricular unloading device, the impeller. And that's why the concept is called ECMELA. You have probably all seen this publication that was some while ago from the group in Hamburg around Benedikt Schrager. And they were able to show that there's a reduction in the probability of any death if VA ECMO was used in combination with the impeller as compared to VA ECMO alone. But still, it's not a randomized trial. It's a propensity score matching. And so the logical consequence is that there will be another trial. And this is the ongoing Unload ECMO trial, also designed by Benedikt Schrager from Hamburg. And it has started, so completion might probably be by the end of next year. And we're looking forward to see whether a randomized trial is able to demonstrate the same thing as we saw for the non-randomized propensity score matching control. And there's also another ongoing trial in the US. It's called the REVERSE trial, and it also follows up the same concept, but with less patients. It's about 100 patients that are expected to be enrolled into the trial, and completion also is expected by the end of next year. So what are the positive and the negative effects of mechanical circulatory support? If we look at via ECMO alone, impeller, or the combination with left ventricular unloading, be it IABP or impeller, then we have a benefit for organ perfusion in all of these devices. The hemodynamics are a bit more supported if we use the extracorporeal membrane oxygenation, which is understandable. In terms of oxygenation, with the ECMO, we can at oxygen. With the impeller, we can't, and that's why there is a minus. In terms of the coronary perfusion, the VA ECMO alone may not be sufficient enough to increase coronary perfusion due to the increase in afterload and just the mechanism how the oxygenized blood is being pumped into the thoracic aorta. And there is, of course, an increase in coronary perfusion by the left ventricular unloading devices, the impeller, the EIPP, and also the combined therapy. In terms of inflammation, bleeding, and vascular complications, they all did show not any benefit, which is expectable and understandable. So what do we know in summary in cardiogenic shock? Well, we do not know that much. So therefore, I can completely accept what the previous speaker said, that it's the mainstay is currently inotropes. But we also know that if it's an acute myocardial infarction, that immediate vascularization of the culprit lesion is life-saving, and that should be done, that the PCI is the preferred method, that we do need a TIMI-3 flow in these patients to improve the outcome. And if this is all not feasible, then of course there's still the option to do a CABG, especially if PCI fails in left main interventions. And a lower target blood pressure may be acceptable, and catecholamines and vasopressors, it's better if you use a lower dose, but they are necessary to secure the survival of the patients in many cases. What we don't know, and this is probably a bit disappointing if you read the title of the talk that I was supposed to give, we don't know which patient we should select for mechanical circulatory support. We have an idea, we have an understanding, but we don't know if that understanding, if the idea is right. We don't know which device we should use. At least at the moment, it looks like the VA ECMO is not the device we should use as a standalone device. On the other hand, we all have seen the 35-year-old patient with a premature acute myocardial infarction complicated by cardiogenic shock that has been resuscitated for 30 minutes, that has successfully undergone the primary PCI, but still there is not an output, and the patient was put on VA ECMO, and the patient recovered, the heart started beating again, and the ECMO was explanted after 4 days. So we all know one of these patients, but we can't be sure whether we select the right patients at the moment. And the timing of the implantation of the mechanical circulatory support also is crucial. So in ECLS shock, about 50% of patients were implanted after primary PCI, but within 24 hours. But a lot of them were also implanted more or less simultaneously. So we don't know which is the best timing of the implantation. Of course, it is within 24 hours, but has it to be done before PCI, or can it be done during or after PCI? We don't know. Thank you for your attention.
Thank you, Dr. Andrew. You hear me?
Yes, I can.
I want to ask you about the last, in spite of there is no difference in mortality between different maneuvers, and what you advise was in your country or your center using ECMO with Ampella, in spite of there's no large study?
I think it's a very difficult decision, and it should be case-based, if it is available at all in your department. For me, the more soothing result from this trial is that a patient with a cardiogenic shock that is a result of acute myocardial infarction does not necessarily need to be transported 1 hour away to a big center where you have an ECMO available at this stage. We don't know, maybe there are some patients that really need to be brought to these hospitals, but we don't have ECMOs available in every hospital where we do 24/7 acute MIs. So that's probably one of the main results, at least for our daily business. But still, if there is a patient 40 years of age without any other diseases, but just a severe acute MI complicated by cardiogenic shock, and you can't help this patient just with reperfusing the artery and with vasopressors, then of course, if available, I would probably use the ECMO, and if the patient really needs left ventricular unloading, I would, if available, if the expertise is available, I would also use the impeller. But if this is improving the outcome in that particular patient, we still don't know. So therefore, it's difficult to give an advice. I think it's too early to stop using mechanical circulatory support. But on the other hand, it probably is a bit more relaxing if you don't have this available on a routine basis in your department. You're not really forced to buy it and to implement such a program at the moment.
Okay, thank you, Dr. Edno. And we move to the next session, which is how would you manage cardiogenic shock in patient with critical aortic stenosis by Dr. Mohammed Osman from Asyut University. Go.
Thanks, Mr. Chairman, and it's my pleasure to introduce this presentation. So, it's okay. 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 So, our presentation today is about the management of patients with cardiogenic shock related to severe aortic stenosis. In patients presenting with cardiogenic shock, the incidence of aortic stenosis is close to 6%. Historically, mortality was up to 70% if no valve intervention is performed during index hospitalization. These patients have poor prognosis with high morbidity and mortality, reached up to 75%, and high operative risk up to 25%. The management of this patient is associated with high mortality, as they don't have the reserve to withstand any complication. Medical therapy alone is almost always insufficient, and surgery is often avoided due to high surgical risk. During the latent phase of the disease, a near normal cardiac output is maintained through a balance between the preload that is elevated to provide an adequate stroke volume and afterload that is also increased to preserve perfusion pressures. But there are a lot of factors that affecting preload and afterload that may precipitate the acute decompensation, as loss of diastolic filling by atrial systole in patients with atrial fibrillation or AV dysynchrony, shortening of the diastolic filling period in case of tachycardia, or decreased forward cardiac output with bradycardia. Also impaired LV relaxation because of acute myocardial ischemia, and abrupt volume shift associated with relevant blood loss or dehydration. So the management of cardiogenic shock should be individualized. And the decision is either to perform high-risk transcatheter aortic valve intervention or attempt to stabilize the patient with circulatory supports. The problem is the evidence are lacking on emergency transcatheter aortic valve implantation in cardiogenic shock, as patients with cardiogenic shock or hemodynamic instability due to severe aortic stenosis were excluded from randomized TAVI trials. The initial partner and core valve randomized control trial excluded hemodynamic unstable patients. So we start with medical therapy. Medical therapy for those patients with aortic stenosis and cardiogenic shock should include optimal ventilatory inotropic support and treatment of the precipitating factors. And vasopressors and inotropes improve tissue perfusion and are usually indicated in case of cardiogenic shock. However, they increase the risk of major arrhythmias as well as worsening of myocardial ischemia, as previously mentioned. But phenylephrine is a vasopressor of choice in treating patients with hypertension with aortic stenosis. As a pure alpha-1 agonist, phenylephrine increases diastolic blood pressure and thus improves coronary perfusion. There is a limited experience with the use of levosimendan in these patients, and its use was associated with improved hemodynamics and cardiac function among acute heart failure patients and severe aortic stenosis with reduced ejection fraction. Also, many of these patients are in need to undergo emergent PCI. However, it's associated with high risk of adverse events during the procedure. Balloon aortic valvuloplasty was described by Alan Crepier in 1986. After initial enthusiasm in the 90s, the use of balloon aortic valvuloplasty dramatically decreased because of the early high restenosis rate, and it was reserved just for palliative indication as mentioned by the ACC guidelines. that balloon aortic valvuloplasty may be considered as a bridge to surgery or TAVI in hemodynamically unstable patients who are at high risk of surgery. The previous studies of balloon aortic valvuloplasty in aortic stenosis patients with cardiogenic shock who underwent successful balloon aortic valvuloplasty reported that 30-day mortality reached up to 47% and at 1 year mortality up to 70% and 2 years mortality up to 90% if nothing else is done, just balloon aortic valvuloplasty. In these two studies, reported that despite the initial success of urgent balloon aortic valvuloplasty, morbidity and mortality of cardiogenic shock related to severe aortic stenosis remain high and directly related to the time of valvuloplasty. So performing balloon aortic valvuloplasty before or within the first 48 hours of starting inotropes agent appear to be a key of survival. Also, mechanical circulatory support can be used, and the feasibility of using Impella in patients with aortic stenosis has been previously reported in few case series. Only one recent study has investigated the use of Impella device following emergency balloon aortic valvuloplasty, as it's impossible to use it just without balloon because of the severity of aortic stenosis. It mentions that Impella 2.5 can be used as hemodynamic support in those patients following emergency percutaneous aortic valvuloplasty, and it may help to improve tolerability of PCI in these high-risk patients. What about TAVI? In 2016, Christian Ferka analyzed 27 patients with cardiogenic shock treated with TAVI. And he reported that TAVI should be considered as a reasonable rescue therapy in patients with cardiogenic shock secondary to compensated aortic stenosis. In univariate and multivariate analysis in this study, they concluded that mechanical ventilation, acute kidney injury, and low cardiac output are associated with increased mortality rate. Recently, in 2021, a meta-analysis included 14 studies reported higher incidence of 30 days in hospital and 1 year mortality after emergent than elective TAVI. But the latest study published in 2023 in the European Society of Cardiology reported that included patients underwent TAVI with balloon expandable valve SAPIEN 3 and SAPIEN 3 Ultra in USA in period between June 2015 and September 2022 that have 5,000 patients with cardiogenic shock. It reported in hospital and 30 days outcomes, mortality and morbidity were significantly higher in patients with cardiogenic shock compared to non-cardiogenic shock patients. But at 1 year outcome, the rate of stroke, life-threatening bleeding, major vascular complication, new dialysis, atrial fibrillation, and PCI were higher in cardiogenic shock. So it's all about morbidity and not mortality. And this study demonstrated that TAVI is an effective treatment for aortic stenosis presented with cardiogenic shock. And patients who survived the first 30 days after TAVI had a similar mortality rate to those who were not in cardiogenic shock. And this is to conclude what about TAVI, that aortic stenosis and cardiogenic shock always come in a late presentation. Systolic and diastolic heart failure presentation can come, and it's mostly an elderly patient with high morbidity and mortality rate in 30 and 2 days and 2 years mortality. But TAVI remains a safe and effective treatment for patients with aortic stenosis presenting with cardiogenic shock. So a shock team approach is described. It includes the use of heart team that have heart failure cardiologist, interventional cardiologist, cardiothoracic surgeons, and ICU physician. If this patient is eligible to have a TAVI protocol just by CT or transesophageal echo in the first 6 hours, so just proceed even to TAVI or balloon aortic valvuloplasty and followed by TAVI. And if indicated, hemodynamic support with intra-aortic balloon or ECMO can be used. So if this patient is not eligible, so just balloon aortic valvuloplasty. Sorry. So if this patient is not eligible, just do balloon aortic valvuloplasty. And if the patient is stable, proceed to TAVI. If the patient is not stable, so just palliative care until something new can happen. In conclusion, TAVI appears to be a reasonable treatment option for patients presented with acute cardiogenic shock. These patients are at high risk of death at 30 days and remain high morbidity up to 1 year after the procedure. Mortality is not related to procedural complication, but rather to the degree of shock itself. And shock training approach is recommended for better outcomes. And thank you.
Thank you, Dr. Muhammad, for your very concise and informative talk. Any question from the floor? For the sake of time, now we are going to close our session.